Let's talk about mechanical bioeffects. There are four broad categories, of which I think one is very important and three are kind of marginal. The three marginal ones are radiation force, acoustic streaming, and non-bubble mechanical effects. Radiation force is essentially torque or pressure applied directly to the tissue from the force of the ultrasound. Acoustic streaming is kind of ultrasound wind. If you remember the force that we talked about from that analytic balance earlier in the lecture, that's kind of what we're talking about here. If you place the probe over a vessel or some other fluid collection, you can actually circulate anything in that fluid. It'll move away from the probe because of the force of the ultrasound. Non-bubble mechanical effects are a little more complicated. In areas where the body already has gas, the lung and the intestine, for some reason extended ultrasound exposure can cause red blood cells to just suddenly show up on the wrong side of the capillary membrane. Even using histology, you can't find holes in the capillaries, just red blood cells on the wrong side. The most important mechanical bioeffect is cavitation, which is the formation and sometimes the collapse of bubbles in ultrasound. We'll talk about this one more extensively. There are two types of cavitation: stable cavitation, where the bubbles do not collapse, and inertial or transient cavitation, where the bubbles form, grow rapidly, and then collapse, giving off a lot of heat and pressure changes. In stable cavitation, a bubble forms as the peak low pressure region of an ultrasound pulse passes through a nucleation site. This bubble then grows and shrinks with the high pressure and low pressure regions of the ultrasound pulses. This growing and shrinking of the bubble causes fluid to flow around the bubble, sometimes very quickly. This flow is called microstreaming. In inertial or transient cavitation, bubbles form in exactly the same way, but because inertial or transient cavitation happens when you use higher pressures or higher intensities, these bubbles form, expand very quickly, and then collapse violently. This collapse can produce temperatures in the thousands of degrees C, pressures as high as hundreds of atmospheres, in a very small volume, sometimes as little as micrometers. The high heat and pressures involved can create highly reactive chemical species, and can physically damage cells in the region of the collapse. Again, on the order of very small volumes. What's really important to remember about inertial or transient cavitation is that this is a threshold behavior. You need to get to a certain level of pressure before transient cavitation will happen at all. There are two places where you see cavitation in diagnostic ultrasound. The first is in non-contrast studies when you use high power settings. Under these circumstances, the peak negative pressures produced by the ultrasound pulse create areas of low pressure in the tissue. Recalling basic chemistry, under low pressure, gas solubility decreases. So gas already dissolved in the tissue precipitates out, much as it would when you open a bottle of pop. The measurable quantity that we can talk about that's most related to this is the spatial peak pulse average intensity, the SPPA. The other situation in which cavitation is relevant is in bubble contrast studies. In these studies, the sonographer purposefully injects bubbles into the body to improve visualization of structures. You may have seen these on the reports as a Definity contrast study. Under these circumstances, the regular pressures involved in diagnostic ultrasound are enough to pop or inertially cavitate the bubbles that have been injected. This is more likely to cause relevant tissue damage than naturally occurring inertial cavitation. However, this is a potentially useful effect, and there are research groups trying to see if this can be used as a drug delivery method. Knowing what we know now, let's return to mechanical index. Mechanical index is a calculated number based on ultrasound parameters and facts about the ultrasound machine that the manufacturers build into the programming. It's an approximation of mechanical effects. It's a gauge of cavitation onset. It is not a gauge of bioeffects once you reach the threshold. The most important thing to know about mechanical index is that so long as the mechanical index is less than or equal to 1.9, you're almost certain not to have any bioeffects. It's specifically not useful in color Doppler. Let's pause for another question. Inertial cavitation is unlikely when the mechanical index is less than which of the following? 10, 3.14, 1.9, or 0.1. You may pause the video to decide on an answer. The answer is C, 1.9. Inertial cavitation is unlikely when the mechanical index is less than or equal to 1.9. As with any study, we use ultrasound when the benefits outweigh the risks. And although I've just gone through the risks in quite a lot of detail here, the risks of ultrasound are still quite low. To keep ourselves in line when using ultrasound, we use something called a LARA, as low as reasonably achievable. You want to use the lowest power and keep the risk as low as you can and still achieve your goal, which is to obtain good ultrasound images. We do this in a variety of ways. For example, we use receiver gain instead of transmitter gain, because receiver gain does not increase the amount of power we use. We use a reduced exposure time. We expose patients to ultrasound as little as possible to get the images we need to get. So long as you do that, you'll minimize the risk to your patient. I'd like to briefly touch on some methods to reduce acoustic exposure. You always want to use the lowest power possible. If you do not have access to a power or a transmit gain knob on your machine, then the best way to do this is by using the appropriate manufacturer preset for the scan you're performing. If you're doing a transabdominal scan for pregnancy, rather than use the general abdominal settings, switch to the OB settings, which use reduced power, as the window of the uterus and amniotic fluid is a very good window, and that allows you to minimize ultrasound exposure to the fetus. Reduce the exposure time as much as possible. Minimize the time that the probe is on the patient. And recall that many of these effects are localized, so move the probe around. Use different windows.